Okay, so the best to the last presentation before the lunch, and we're going to talk about, guess what? Nutrition and hydration at the end of life. So Dr. Shabbir Alibhai, he will talk to us about the Islamic concept about the hydration and nutrition at the end of life. Dr. Alibhai is one of my teachers, and he is, I'm just trying to find his name, and he is currently a geriatrician and researcher at the University of Health Network. Dr. Alibhai is the medical lead of Older Adult Cancer Clinic at Princess Margaret Cancer Center. He's also an associate professor at the Department of Medicine, the Institute of Health Policy, Management and Evaluation, and the Institute of Medical Science at the University of Toronto. He has a long-standing personal educational interest in religious biomedical ethics, focusing on end-of-life issues and comparative bioethics. He has lectured internationally and published articles and book chapters on Islamic and comparative religious biomedical ethics. Dr. Alibhai.
Thanks very much. I have no disclosures. I begin in the name of God, the most merciful, the most compassionate. For those who don't know the Arabic, this is an Arabic calligraphic representation of that invocation. I've been asked to cover the topic of nutrition and hydration at the end of life before lunch. I don't know why it was chosen in this time, and Ahmad's already stolen my thunder, but you can think about death and normalize death as you eat your lunch, perhaps. I'm going to cover 5 key things in the next 20 minutes. What is this issue and why is it important? I'm going to give a couple of introductory remarks on Islamic laws and ethics as they apply to help us conceptualize the issue, and then we'll jump straight into focusing on nutrition and hydration issues at the end of life, some persisting ethical challenges after developing a framework, and then conclusions and next steps. And I do have some slides in here that I put in. Not sure how much Professor Sajidina or Dr. Padella would cover, but I'll be skipping those because I anticipated they would cover them. So why is this important? As has already been mentioned, when individuals are no longer able to intake enough food and water to be able to meet their usual metabolic needs, we get concerned about whether or not we need to intervene in order to be able to meet a perceived mandate. And we'll come back to that. But it is a common scenario that occurs towards the end of life in various populations, of course, Muslims and non-Muslims, but in people who have a variety of illnesses, advanced dementia, stroke, cancer, various neurodegenerative diseases, and so on. So it's a common condition that happens to many, but not all who are dying. And we also know, and people have talked about earlier among our speakers, that there is advanced medical technology in the last few decades has really changed the way we think about what is death, how do we define dying, how we can keep people alive longer and in new ways compared to what we used to be able to do. So not only can we extend life and promote organ function longer than we ever could before, our very definitions of death have changed compared to when our religion was founded 1400 years ago, and of course other religions even earlier. Along with all of these areas, including our changing understanding of death and brain death, etc., nutrition and hydration are not as clear as they used to be. Once upon a time, if people couldn't eat or drink, you could only get a certain texture of food and a nice spoon and encouragement, and that was it. Now we have intravenous tubes, parenteral nutrition, etc., and these are relatively easy to order and institute, but sometimes much more difficult to decide whether we should, even if we can. So from a secular ethical point of view, there are several issues that arise that lead to conflict between Muslims and non-Muslims, or those of different faith groups that have perceptions around nutrition and hydration at the end of life. 3 issues come up, the most important of which is the notion of non-maleficence that others have talked about. But the notion that we may be causing harm or harms or some degree of suffering, and Asim has talked a little bit about that, although it's a complex area, but are we doing more harm than good by trying to keep people alive with this nutrition and hydration when before it would have been a natural response in many people who were dying that they would no longer want to eat and drink, and it was part of the naturalized dying process. And we have tried to separate it, and in fact, are we doing a disservice? There are concerns around the notion of human dignity and naturalness, or hurma and karama, come up in terms of personhood and how intravenous fluids, feeding tubes, etc., are violating human integrity, and that cost needs to be considered when thinking about the various needs and ethical imperatives that we need to balance. The last issue that rarely comes up in ethical discourse is around limited resources and costs. It comes up in other areas, but not really in this area, nutrition and hydration, probably rightly so, but I'm not going to focus in on that. Pragmatically, what happens, and I deal with a number of Muslim patients like many of you, and I struggle when they ask me, can we go to palliative care? And several issues come up, particularly around can we accept DNR, which I won't talk about. But the vast majority of palliative care units, as already alluded to, will not accept individuals who are receiving nutrition and hydration at the end of life through means other than conventional oral routes. And this becomes a challenge because many people are in hospitals where they were getting intravenous fluids or have feeding tubes, and all of a sudden we're talking about dying and we're going to pull these devices. And this becomes problematic at a pragmatic level, whether ethically or not, but at the pragmatic level. So you've heard about our sources of laws and a little bit about that, so I won't touch on that. We've heard about the principles of sanctity of life as one of the primary principles, but also recognizing that we do not always need to prolong life, and there are other factors at play. Professor Sachedina talked about some of these in the context of the complex individual patient. It's not always about prolonging life, and the Sharia talks about cure, but not necessarily about prolonging life. Whereas modern medicine, other than some areas of surgery and some areas of oncology and most areas of infectious diseases, the rest of medicine is mostly about managing chronic illness. Prevention, yes, but once you've got it, we don't cure that many people. And that's not a bad thing, it's the reality, but we can manage people for decades with some conditions. Look at what we've done with HIV, for example. We also talked about suffering, and it can have both good and bad qualities. And I'm not going to get into that in much further detail, but just to bring that back to the notion that when people talk about a perspective of whether we should be giving artificial nutrition and hydration, and people bring up the notion of suffering, secular ethicists and physicians will not see suffering in the same way as many Muslim patients and their families. And whether or not, in fact, giving these intravenous fluids or peg tube feeding, in fact, may aggravate suffering, and is that a bad thing? So I won't talk more about sanctity of life, but I will touch a little bit more on the notion of duties. So some ethicists have described the Islamic bioethical system as a duty-based system, which has its pluses and minuses, but it's one way of thinking about it paradigmatically. And so we do have a duty to try and prevent harm or illness, ad-darar, as mentioned, and to try to seek out treatment for illness to preserve life and prolong life. Not at any cost, and Asim did go over some of the sectarian differences between the different schools of thought. But in general, the hadith has been mentioned before, and we are obligated to seek out treatment to prolong life if there is certainty that it will do so, provided that it does not have significant harms. That I think almost everyone will agree to. The devil's in the details. What are the harms? How much life? Prolongation, cure, etc. But prolonging life takes precedence over quality of life in almost all the discussions, both classical and modern, from an Islamic perspective. But the principle is not without limits. In other words, quality of life when it gets to a certain level or causes unbearable suffering to people is something that cannot be ignored. And the notions of hurma and karama and that dignity, those come back into play at a practical level. We also talked about suffering, and so I won't talk more about that, and the notion of faith in Allah as opposed to faith in modern medicine. But these issues become interesting when trying to apply to practical level. So let's frame the question. Must an observant Muslim accept, quote unquote, artificial nutrition and hydration? I'll use that terminology even though there are issues with it. And is artificial nutrition and hydration in fact a medical treatment, at least from Islamic bioethical and theological discourses? And then if so, the paradigms, in fact, of accepting and declining treatments do depend to some extent on the patient's madhab, if we accepted that it's a medical treatment. So Asim talked about, and so I won't get into a lot of the details around harms and perspectives in different faiths, but I will mention this, that, for example, there were a couple of papers that have presented the notion of harms and how we think about, at least from a Shari'i perspective, 5 major levels of harm that can occur with actions that the jurists will weigh. And each of these are weighed to some extent in priority, but not always. There's complexity. But preservation of the faith comes at the highest level, sustenance of life and preserving of life, and the intellect, so that conscious ability to be able to worship God, one's lineage, or family, and of course one's wealth. And each of these are potential harms depending on courses of action. And so all of these harms get considered juridically when thinking about whether we should or should not do certain things. We also spoke about karama and hurman, so I won't belabor the points, but that Asim made this point, and others have as well, that towards the end of life, the majority of treatments become increasingly disruptive to karama and hurma to a significant proportion of patients. And artificial nutrition and hydration are not exempt from that, and they must be considered. I'm not going to go into the schools of thought because Asim did cover that, but the notion is that not all of the major schools of thought among the 4 classical schools in Sunni thought and Shia thought agree completely. There are some differences of opinion around treatment and acceptance of treatment. However, this issue for artificial nutrition and hydration is in fact not around treatment. The majority of scholars have argued that in fact nutrition and hydration is not a medical treatment from classical Islamic perspectives. It is in fact an area within our duty of providing basic care to people versus medical care. And so there's a couple of issues here that I'll touch on. The first is the notion of the need to feed, that I'll come back to in a moment. The second is that we have a duty to try and relieve suffering, and one of the sufferings that is alluded to within the Quran and the Hadith traditions is starvation as one of those evils or one of those terrible things that we should all try and overcome to help those who may be starving or may be suffering, and those two are not always connected. But the religious scholars and thinkers within the faith have none, as I'm aware of, have considered nutrition and hydration to be a medical treatment. In all the discourses, it is considered to be part of basic care. Some other faith traditions have talked about ordinary versus extraordinary means, and I just highlight that Islam doesn't discuss it in that fashion from most of the scholars. But there are 2 conditions to think about when trying to formulate an Islamic ethical response to my question earlier, which is, are Muslims obligated to accept A&H? The first consideration is sanctity of life, and the second one is the duty to feed. We've already talked about the sanctity of life, so let's talk a little bit more about the duty or the need to feed. There are traditions within Islam that strongly recommend that we should be feeding those who are sick, and there is a social duty that all scholars, that goes back to the traditions from the Prophet and the earlier scholars, that we have a social duty to eradicate hunger. This duty has been argued by a number of people, and I've tried to put some of it together in an essay I wrote almost a decade ago, includes at least 3 important elements. The first is potentially providing financial resources to people to be able to procure food for those who are in circumstances where they do not have sufficient food. The second is to provide that food to people who don't have the means to be able to prepare it themselves. And the third is to assist with the preparation of the food or the delivery of the food to mouth. And all 3 have been discussed, and all 3, I believe, and have argued, and some others have as well, are encompassed within this duty of the need to feed. However, there are some issues that we need to dissect further. First of all, one of the ethical obligations that I've talked about from a Sharia perspective is that we should be relieving starvation. Now, many people, as those of you who do palliative care know, as they are progressively dying, no longer actually feel hunger. And so if people are not feeling hunger, for a variety of reasons, we can talk about the anorexia, cachexia pathway, etc., but do we have a duty to feed them when they're actually not feeling hungry? Is this part of the normal physiological response? So the Islamic tradition, as I have understood it and as I've argued in my essay, is that it is not our duty to force feed people who are able to choose and make choices, and even if they don't eat a lot, but if they are withdrawing from food as part of whatever response to their illness or towards the dying process, we are not obligated to do any more than encourage, provide, assist, but we don't force. So that's the first principle. The second principle in our response is that the oral route is always best. There are people who may want to eat or drink a little bit, and they may have difficulties at times because of pain or weakness or other factors, and we can assist them, and in doing so we have met our duty of the need to feed. Even if they are not meeting their kilocalorie equivalents, even if they are not getting in X number of milliliters of fluid per day, we are not obligated to offer nutrition and hydration through other means if we are meeting these basic needs and people are taking in at least some small sips of fluid or having some amounts of food. So those meet the minimum need to feed from my understanding of perspectives and principles, and from my discussions with scholars. I would value input from some of the scholars in the room. If we want to resolve the issue in more detail, we have three different potential pathways. Either nutrition and hydration for a given patient will prolong life. For example, they've had a stroke and likely will live for a number of years. It may potentially hasten death. For example, oral feeding in people who are high risk of aspiration and are likely to develop pneumonitis or pneumonia, and we know the morbidity and mortality of that. Or it may be neutral for that patient based on our best medical evidence. If, as others have argued, there is reasonable certainty that feeding is going to prolong life, then there is little discussion and controversy among the scholars. We need to feed. And if we cannot do so safely through conventional means by mouth, then artificial nutrition and hydration is obligatory for that patient to accept. Whether they choose to or not is their choice, but it would be obligated if they are observant in trying to follow Sharia. Similarly, it's very clear that if there is reasonable certainty, and again, if you ask the imams, they will work hand in hand, as Professor Sachedina mentioned, or even the chaplains, with the medical experts to say, in this case, is there likelihood that we are going to cause harm? Whether feeding through a PEG tube or nasogastric tube or giving fluids in a person who, for whatever reason, has medical contraindications, and there are people like that. In those circumstances, in fact, the duty would be not to provide artificial nutrition and hydration because we may be accelerating death if we have reasonable certainty. The third scenario is if feeding is thought to be, on the basis of the best medical evidence, neither likely to prolong life nor likely to hasten death, which comes up, what do we do then? This is where there is a little bit more of a dilemma. So if feeding does not prolong life, nor does it likely shorten life, then we recognize that there are a couple of ways we can give food and fluids. Part of that duty to feed, I believe, is providing food through parenteral means or enteral means, depending on whether they have a functioning gut. And as I mentioned, it is considered a part of basic care. So if it is ethically neutral from the perspective of prolonging life versus prolonging death, then my argument is in people who can no longer take anything by mouth, then we do have a duty to provide some level of nutrition and hydration through this artificial means. And of course, the Sharia doesn't talk about it as artificial, doesn't make that distinction. It is part of the duty or the need to feed. However, there are not a lot of formal fatwa on this that I have found to date. That being said, there are 4 areas that I will highlight where I believe there are ongoing ethical issues that need further thought, deliberation, and clarification. So first of all, if we go back to the Sharia, and I'm certainly not an expert on Quranic exegesis and on theological thinking, but how extensive is this duty to feed? My interpretation and my understanding from the Sharia is, in fact, is that correct? I have not seen a lot of scholarly talk with detailed discussions about an exposition on the duty to feed and connecting it to modern healthcare, and I would welcome that, particularly when people don't feel hungry, when they're not complaining. It's not a financial obligation. They don't have concerns being able to buy the food. They can swallow, but they just don't want to eat. How far do we need to go, and where does the duty end, and how do we incorporate some of these increasing harms and thinking about the integrity of the body and the dignity of the person? And are there differences among the schools of thought? I have not received or seen a sufficient body of fatwa to be able to differentiate clear positions among the 4 classical Sunni schools and Shia schools so far. It seems everyone's in that same camp, but I think it would be worthy of getting further scholarly opinion. Third issue is that should we be thinking about resource constraints at all? Are there really significant costs associated with fluids, with feeding tubes, etc., and should that factor in? Perhaps part of the issue of resources is they can't get into a palliative care unit. And is that something we should consider? I'm going to come back to that one, though, because I can't resist at the end, and I'm going to challenge Ahmed and OPCN and others on that. And how far does one go? For example, in my world, in geriatrics, we have a lot of patients with advanced dementia who are not able to eat and drink for a variety of reasons. Some of them, if we put in feeding tubes or intravenous fluids or even subcutaneous fluids, it is perceived to cause agitation. We can observe it. And some of them will pull out those tubes. And how far do you go in restraining people to be able to meet the need to feed, or this duty to feed? Because we are violating hurma and karama in doing so, and imposing an increasing burden on families and caregivers. And how does one balance that? So far, I have not seen clear juridical rulings integrating that information, and it's a daily challenge I face in dealing with people with advanced dementia. Let me end off. So artificial nutrition and hydration, in conclusion, is ethically obligated to meet the duty to feed in situations where oral feeding is not feasible and feeding is not harmful, whether or not it is going to prolong life or is neutral towards life prolongation. Second, artificial nutrition and hydration is not considered, I'm sorry, there's a typo there. It is considered basic care rather than medical treatment by all major schools of thought. My apologies, that's an important typo. The third point is that there are a number of ethical issues and theological discourses that I think still need to happen to clarify elements of nutrition and hydration. And it's important to point out, as several others have, that just because people are Muslim, whether name or by last name or by assignment, they are not all going to see this issue the same way. There are cultural differences, there are individual differences, but I'm trying to present an ethical, theoretical response to the question that I'd posed. Whether individual patients and imams and others will ask and think in the same way is a separate issue, but I present the theory. What I do want to challenge people in the last few minutes is I believe that palliative care units need to look critically at this assumption or this culture, as the previous speaker called it, that we do not give fluids even, let alone food, in people who cannot eat and drink by conventional means. And I would like to understand more why, and I'd like to look critically at these policies to see whether it is reasonable and really ethically justified to demand that people not accept nutrition and hydration in order to be able to get into a palliative care unit. And really, are these philosophies right now that exist in these units, is it really cultural? Or is there a philosophy that we need to name and discuss critically? And is that philosophy founded on certain philosophical or moral values that may in fact be ones that should be challenged in a pluralistic society, and particularly if we want to be inclusive towards more observant Muslims? Thank you very much. Now you can eat and drink normally before the end of life, I know, before the end of today.
Thank you for a very, really informative presentation. A very specific question, I guess. If artificial nutrition and hydration has already begun, are there ever any circumstances when it can be withdrawn? Say if there's a perception, say from the medical team, that it is causing increased suffering or harm to the patient.
So it's a great question, and absolutely. There are tensions, as I think Professor Sajidina alluded to, although I know he had a lot to cover, between Shia and Sunni thinkers around withholding and withdrawing treatments in general, particularly those treatments that are going to immediately lead to death. For example, the ICU. Classically, within the Shia juridical schools, particularly, for example, Ayatollah Sistani has gone on record, and it's very clear, and we have these case reports that come up over and over in Chicago and in other centers in North America, and I'm sure they occur in Europe, where if you withdraw a treatment that you have already begun, that is a life-sustaining therapy, for example, the ventilator, dialysis, etc., then withdrawing that therapy is morally not equivalent to withholding it in the first place from the Shia juridical point of view. The major Sunni schools of thought differ distinctly from Ayatollah Sistani in this, but even within those schools of thought there are some minor differences. To answer your specific question, however, if there is clear and mounting evidence from medical experts that provision of artificial nutrition and hydration is causing harm, particularly if that harm is to be associated, if there is certainty, reasonable certainty in that, and if it is likely to be associated with shortening of life, then absolutely. All schools of thought will agree there's no problem. If it's going to be associated with increasing harms, and those harms include suffering, that's where I think you need to have an individual discussion, understanding the patient, their family, the particular school of thought they may be coming from, and the culture within which they operate. Many Muslims at that stage, when faced with a sensitive discussion with the healthcare team about these are the harms that we believe that may be being caused, this is the suffering, these are the potential indignities to the body, then many of those patients and families and their imams will say in these circumstances it is reasonable to withdraw that care, and particularly even whether they are Shia or Sunni, there will be comfort, particularly, as I mentioned, if there is risk of shortening life. But if not, around the harms issue, there is less concern from the perspective if other harms from Sunni schools of thought being able to withdraw. Some of the Shia scholars, in that case, in scenarios I've encountered, have raised objections and said, you started it, and if you don't have clear evidence that you're shortening life now you cannot stop it. So there are some tensions there, but in general it's much easier for Sunni schools of thought, for patients following those schools, and also when there's concerns that life may be at risk with ANH. Uh-oh. Oh, good.
Was there a question there?
Yes, another question, not from him. No, I'm kidding.
I think we'll have more discussion about the artificial hydration and nutrition in the panel discussion.
Okay, sure.
The palliative care will respond.
Fine. So I shouldn't ask him a question.
Well, if you want to keep it till the...
I can ask him on the panel. That's fine. That's no problem. I won't ask you the question. I'm going to tell you the scenario. Then you can think about it. You don't have to answer.
How's that going to help right now if you give us a scenario?
Think about it. I was at a Catholic bioethicist talked about this scenario. I don't have an answer. I don't know if you'll have, but I want you to think about it. So it won't be. So the issue was: are we complicit for an individual who's decided that their means of dying is starvation? Are we complicit by not providing them food? Right. So they've decided that's how they're going to end their life. They've told you that as their physician, and now if you are on the camp that I can't assist with suicide, then not doing something, would we have a moral obligation to, recuse ourselves? What is the scenario? That's the scenario.
I'm happy to discuss it later, but I have an answer for that. It's actually, to me, there's very little ethical dilemma there, but we can talk about it later. We'll pause for lunch.